We are about to start with the main part of this afternoon. Our guest today is Dr. Gottesman, Dr. Rebecca Gottesman from the National Institutes of Neurologic Disorders and Stroke. She is the branch chief and senior investigator of the Stroke, Cognition, and Neuroepidemiology section at the National Institutes of Health. We are also funded by the National Institutes of Health, but we're all with the National Institute of Aging. In any case, Dr. Gottesman is a graduate of Columbia University, where she got her medical degree and did her neurology fellowship. She has also completed a PhD in clinical investigation at the Hopkins School of Public Health and was previously on the faculty in the Department of Neurology until she decided to come join us in the federal government and the National Institutes of Health. So she's going to talk to us today about the effects of stroke on cognition and the things that we should be very much aware of. So at this point, Dr. Gottesman.
Thank you so much. I'm sorry that your video didn't work, but it looks like mine is working for now. Thank you so much for being here with me this afternoon. That was a really great introduction to being able to learn something about cognition and dementia, and you'll see that I'll talk a little bit about physical activity briefly during this talk, so it's very appropriate as well. So I'm going to go ahead and share my screen, which I hope you're able to see. So I'm going to talk a bit about vascular dementia, and you might notice that I added a little bit more to this title beyond just vascular dementia. And really, what I think is a more valuable take-home message is not just to understand what is this concept called vascular dementia, but is there an aspect of dementia that can be modified or even prevented? And that's really what I want to talk about today. So what is vascular dementia? First, I know that there have been many sessions about dementia, and this seems to be an area that you've had a lot of educational sessions recently, but just to make sure we're on the same page in terms of defining it. So dementia broadly refers to the condition where you have loss of cognitive function that's sufficient enough to interfere with daily activities and with function. Alzheimer's disease is the most common cause of dementia. So dementia as a broad condition affecting cognition. Alzheimer's disease is one primary type, which I'm sure you're all familiar with. But the term vascular dementia generally refers to another type of dementia, another cause of dementia, which causes the same problems in cognition, affects daily activities as well. Usually the term vascular dementia refers to a condition where people have a series of strokes or stroke-like changes, and they gradually have worsening of their cognition. And I put some MRI examples here on the side of the slide to show you what an MRI might look like in somebody who's been diagnosed with vascular dementia. So on the top, this is an example of someone who had a fairly large stroke and may have had problems after that stroke with their memory and their thinking and their daily functioning, and be given a diagnosis of vascular dementia after that stroke. Many people have strokes and don't develop dementia, but this is an example of someone that might. In addition, we see changes in the brain that don't necessarily present clinically as a stroke. So a stroke is when someone has sudden loss of blood flow or bleeding in a part of the brain, and then they have sudden weakness, numbness, difficulty speaking, difficulty seeing, double vision, severe vertigo, one of those changes, for example, difficulty walking, or some combination of those changes. So even without a stroke, someone might have stroke-like changes in the brain that accumulate over time, look like a stroke when we look at imaging. This obviously looks a little bit different here. This is a specific type of these changes that doesn't look quite like a stroke, but is probably caused by similar risk factors. And we'll talk about those risk factors very soon. And so stroke-like changes in the brain can also accumulate over time and cause what we think of as vascular dementia. So typically people with what we would call pure vascular dementia, and I'll tell you in a moment why I'm putting it in quotes, in air quotes at least, have these stroke-like changes either that cause symptoms or don't cause symptoms, and have what we would consider a stepwise worsening of their cognition. So they're okay for a bit, and then they suddenly get worse, whether it's a stroke or other changes in their brain, and then they're okay for a bit, and that gradually worsens over time. Typically, the types of cognitive problems that people with vascular dementia get are different from those that we see in people with Alzheimer's disease. So Alzheimer's disease, one of the major cognitive areas that's affected is memory. Memory is actually generally less affected in people with vascular dementia. They have problems with attention, with what we call executive function, which is really the ability to multitask and sort of plan things in multiple steps. So it looks a little bit different. The problem is that in reality, we rarely see Alzheimer's disease as its own entity, as its own type of dementia, and vascular dementia as a really pure, its own form of dementia. The reality is these things overlap a lot in people. So we've sort of shifted away from the term vascular dementia to use a term called VCID, which is vascular contributions to cognitive impairment and dementia. And that's just a way to say that many things that cause dementia may have a vascular influence. So you can have Alzheimer's disease, but there may also be some vascular changes in the brain or in the body that are happening that affect how your memory and your thinking are. And we'll talk a little bit about that. The reason this is important is that we know how to treat and prevent many different types of vascular risk factors and vascular disease, which I'll tell you about shortly. We don't have a lot of treatments available for Alzheimer's disease or other causes of dementia. We have some, there's newer medications available certainly for Alzheimer's disease, but if you have multiple causes leading to someone to have cognitive problems and memory problems, we want to make sure we're thinking about ways to treat all of those kinds of problems or even prevent some of those problems so that there's less of a chance of dementia down the road. So this VCID concept, vascular contributions to cognitive impairment and dementia, is sort of captured in this Venn diagram, this image that you see at the bottom, which is showing that if we think about vascular dementia, vascular disorders, stroke, things like that, as one category and Alzheimer's disease as another, there's a lot of people that have a contribution to things like Alzheimer's disease from vascular changes. And I'll tell you what I mean by vascular changes. So in general, these are things that happen throughout the body in relation to certain risk factors. It's basically the things that you think of as risk factors for stroke and heart disease. So here's some of the major examples. High blood pressure or hypertension is a major one. Diabetes is another major one. Smoking, high cholesterol, obesity, physically inactive lifestyle. I mentioned how great it was in particular that there was an exercise component before this lecture, and then poor diet, and then sort of broadly, some of these all may cause increased inflammation in the body. So I told you that often we see overlaps and that people don't just have Alzheimer's disease or just have vascular dementia, but have some combination. And this is an example of how we know that. So this was a series of studies done in the Chicago area of actually, it's called the religious order study. So people who had been in there were nuns and monks and people who had been in religious orders that enrolled in these studies and agreed to have autopsies after they died. So another really, really important contribution to the literature where we learned a lot about the brains of people as they aged because of a lot of these important autopsy studies. So what this is showing here, this first pie chart that you see on the left side of the slide is people with no cognitive impairment. So that means when they died, they're functioning at a pretty normal status. Their cognition was good. They might have had some normal age-related changes. We see that in people as they get older, but they didn't have any impairment to reach the point of a diagnosis of either dementia, which is this pie. This says probable Alzheimer's dementia is the AD here, or Alzheimer's disease related dementia. And in the middle, MCI is mild cognitive impairment, which you're probably familiar with, but is generally considered a precursor to dementia. Not everyone with MCI or mild cognitive impairment goes on to develop dementia. It's somewhere in between. So they often have problems with memory and thinking, not yet to the point that's interfering with their daily activities. But what I want to show you here, and this is an overwhelming set of pies, so I want to talk you through this a little bit more detail. For example, if we look at people who had probable clinically, they were diagnosed with Alzheimer's disease before they died, and then they looked at the brains of these people after death, this little tiny pie piece here that says AD is the small proportion of the total pie of these people that doctors thought had Alzheimer's disease that only have Alzheimer's type changes when they looked at their brains. So what that means is this big chunk here had Alzheimer's disease as well as vascular changes, those stroke-like changes that I mentioned that often go along with high blood pressure, diabetes, smoking, obesity, physical inactivity, high cholesterol, et cetera. And then this other OD is other degenerative changes. We know that there's other changes that can happen that can cause dementia that we're not going to go into detail today about. But interestingly, almost half of people that were given a diagnosis of Alzheimer's disease and their brains were looked at after they died had something else going on in addition, and sort of two other types of something else. We're talking about the V for vascular, particularly because that's an area where, as I said, we have things we can do to treat vascular disease, ways to treat these risk factors, ways to potentially prevent dementia. But as you can see, if the V is preventable or treatable for MCI, also for probable Alzheimer's disease dementia, then that suggests there's a pretty big piece of this pie that we might be able to modify risk in and actually prevent dementia. In general, Alzheimer's disease is an increasing problem in the population. The population is older, which is wonderful because we've done a better job at treating acute diseases, things like stroke and heart disease. But people are living to older ages, and that means the rates of diseases like Alzheimer's disease are going up. And importantly, if part of this, what's called Alzheimer's disease, is actually due to things like vascular disease or a combination, as suggested by that pie chart that I just showed you and other studies that support that as well, then it may be that we can help prevent this increase. So not only is that important on a population scale, it's obviously highly important on an individual scale. You want to do whatever you can to try to prevent having problems with your memory and thinking down the road. So this concept of modifying your risk or preventing your risk is something that several different organizations have latched on as really an important message for the public. And some of you may have heard about this before. So this is one estimation that approximately a third of dementia cases can be prevented by addressing these lifestyle factors. I'm going to focus mostly on the factors here that are related to vascular disease. So I'm a stroke neurologist, meaning I take care of patients with stroke, but I really want to know what I can do to prevent long-term problems down the road, not just in people who have strokes, but people who are at risk for having a stroke because of high blood pressure, because of obesity and diabetes, et cetera. Here's another way that we've sort of looked at these risk factors graphically. So the Lancet Commission was a large group that was put together in the UK, where they looked at all of the evidence for different vascular risk factors and looked at their relationship with dementia and created this estimation. This is sort of meant to be the life course. So this is early in life, midlife, and then later life at these different parts of this graphic, looking at the different proportion of cases of dementia that you could eliminate if you got rid of this risk factor altogether. So for example, if we eliminated all low education in early life, we could get rid of 7% of dementia cases. That's a lot of cases. That's not an easy undertaking, certainly, and requires a larger broad scale effort to really improve and reduce low amounts of education. In addition, things like high blood pressure. This is kind of a small percent here, but high blood pressure is so common in the population that really there's a lot of bang for the buck in getting people to treat their high blood pressure. We'll talk about this in a little more detail shortly, and so on. So you can see important risk factors, both vascular, these heart and stroke risk factors, as well as other risk factors. So here it's estimating that 40% of risk, so more than that 1 in 3, about 40% of risk of dementia could be modifiable. We actually looked at this in a study that I was a part of. So I worked with a large study that evaluates people from communities, 4 communities across the US, where we've followed them from middle age through older age. So it's now been 35 years of follow-up. We're continuing to see people. And we are therefore able to understand how their vascular health and their other health when they were middle-aged relates to how they're doing in older age, now that they're 85 plus. So using data from that study and also looking at sort of census data and representation in the communities, we also estimated that these risk factors, particularly high blood pressure, obesity, and physical inactivity, would account for about 41% of dementia cases in the US. So that means if we could get rid of those risk factors, then that would be almost half of dementia cases that those people would not develop dementia. So that's a pretty compelling number. I realize it's unrealistic to say that we can just eliminate these risk factors. So this concept is also, if you could even reduce its presence by 15%, so get rid of 15% of the people that have high blood pressure, prevent those people from having it, you could probably reduce dementia by a fairly sizable percent if you do that for each of those risk factors. And I just want to make an important point that that percentage of dementia cases that's attributed to these 12 risk factors, the risk factors on this graphic, is higher in minoritized populations. So Black Americans, 46%, Hispanic Americans, 47%. So that's really important to think about ways to modify risk. So how is it that these heart disease and stroke risk factors actually lead to problems with your memory and thinking? So one possibility is that they cause strokes. I told you I'm a stroke doctor. We know that these high blood pressure, diabetes, smoking, high cholesterol, obesity, et cetera, are risk factors for stroke. We also know that some people who after they have a stroke have problems with their memory and thinking to the point that it interferes with their daily functioning. Stroke interferes with daily functioning in other ways by causing disability, but in terms of actually potentially causing dementia, we know that stroke is a risk factor for dementia. Again, important to understand that risk factor doesn't mean that everyone with a stroke develops dementia, nor does everyone with dementia have a history of stroke, certainly, but we know that it increases your risk. In addition, there's these silent stroke-like changes in the brain. I gave a few more examples. The second one is similar to what I showed before. And here, this is another kind of brain MRI sequence, which shows these tiny little areas, these black spots here, you can see, are what we call microbleeds or microhemorrhages, which mean that you've had bleeding at some point in the past in your brain, and you probably never knew it. We most commonly see this particular pattern with really elevated high blood pressure over time, people that don't have well-treated high blood pressure. But we know that the more of these that accumulate over time, the greater your risk of having cognitive problems and dementia, just like these kind of scarring type changes in the brain, the more of those that accumulate over time, the greater your risk of dementia. In addition, it may be that chronic exposure to these vascular changes makes you have a harder time clearing toxins from the brain. There's some evidence for that. This graphic is just showing sort of some of the ways that we think vascular risk factors, and this particularly thinking about things like high blood pressure, poor vascular health, how that affects the brain's ability to get rid of toxins, to sort of make sure there's enough blood flow going to the critical parts of the brain to be able to function well. So I'm just going to go through some of these risk factors briefly to give you a sense of why we say that these are associated with dementia risk, why is it relevant, and what we know. And then we're going to talk a little bit at the end about what we know about actually treating these risk factors and reducing your risk of dementia. So high blood pressure, you know, the definition of high blood pressure has changed. Now, this is already 8 years old, this set of updates. But when this set of new blood pressure categories, new definitions came out, suddenly a lot of people were given a new diagnosis of hypertension, high blood pressure. So if your blood pressure was 135 for the top number, the systolic number, it used to be that was considered pre-hypertension. And then suddenly new guidelines, now you have a diagnosis of hypertension. And that's relevant because people don't necessarily know whether or not they need treatment for their blood pressure. So what's important to note here is that even among people who know they have high blood pressure, a pretty high percentage here, more than half of people on treatment for the high blood pressure are not adequately being treated. So hypertension is not necessarily something you're aware of that you have, or aware of that it's not being well controlled. And it's very common in the population. And as a result, many people are not even aware they have it. And of those who are aware they have it, they might not be getting treated as they should. And why is it important? So there's evidence in a number of studies. I'm sharing some of the studies that I've led and been a part of, basically showing you that higher blood pressure. This is when we looked at blood pressure when people were middle-aged. Now, I want to make a sort of brief point, which we can come back to if it comes up in questions, which is that most of the evidence for these vascular risk factors, hypertension, diabetes, et cetera, being important risk factors for dementia in later life, shows that they're most important when you look at them in midlife, in middle age. And what that means is if you have high blood pressure when you're middle-aged, that increases your risk of dementia later much more than if we look at high blood pressure in later life. That doesn't mean it's not important to think about blood pressure when you're older, but really if there's the opportunity, whether it's yourselves or your children or your grandchildren, to say, look at your blood pressure, think about, see if it's well enough controlled when you go to the doctor, because the earlier you can get it under control, the better that is for your brain health. So you can see here higher blood pressure, and this is just showing you the amount of worsening in testing on certain cognitive tests that we see over time. And we similarly see, and I know you can't make out the details of this graph, but I just want to make the point that people that also have high blood pressure in middle age not only have this worsening of their performance on cognitive tests, but have a higher rate of dementia. When we just look at follow people, in this case, this was 25 years worth of this big study that I mentioned that I'm a part of, that they have almost a 40% higher risk of having dementia if they had high blood pressure when they were middle-aged. What about diabetes? Similar to hypertension, many people don't know that they have diabetes. And this is relevant because if it's a risk factor for dementia and you want to do what you can to modify or prevent your risk, then you need to know that you have the risk factor in the first place. So these are old data, but the proportions are not that much better now in terms of the large proportion of the population that has undiagnosed diabetes across the age scale, certainly as people get older. So if you're not sure that you have it, you can't do anything about it to make sure it's well controlled. And similarly, diabetes in the same study where we looked over 25 years to understand how having diabetes when you were middle-aged, how that was associated with risk of dementia over 25 years, we see that if you have diabetes when you were middle-aged, you have nearly doubling of your risk of dementia. That's a very large effect. It's actually as large as what we see for ApoE. So ApoE is the most frequent known genetic risk factor for Alzheimer's disease. So there's a gene that you can inherit. And if you have at least one of these E4 forms of that gene, you have a similar, about a twofold increased risk of having dementia as if you have diabetes. Right now, we can't do anything about the ApoE, the genetic risk, but we can do something about diabetes. So this is really compelling, again, to think about modifying risk. What are risk factors that you want to get under control and ideally try to prevent dementia? What about smoking and heart disease? Just briefly, people who smoked in middle age in the same study had also about a 40% chance increased risk of dementia. And then we know from additional studies that people who have heart attacks, even many years after the heart attack, they appear to have worsening of their cognition over time, independent of the risk factors that cause both heart disease as well as maybe dementia, independent of things like high blood pressure and diabetes, that heart attack may contribute to worse blood flow to the brain, for example, or may lead you to have to alter your behaviors in other ways, hopefully in ways that improve your health, but certainly sometimes we see this increased risk over time for cognitive worsening. What about high cholesterol? It's a little bit less important for the brain than it is for the heart. We know that in general, heart disease risk and death from heart disease go up all around the world as cholesterol levels are higher. It's interesting that certainly different parts of the world have higher levels of cholesterol. Some of that is genetics, as people that live in those different parts of the world, and some of it is diet. And then in general, people with higher cholesterol, I'm just pointing to these top numbers here, have greater risk of worsening of their memory and thinking tests than people who have lower cholesterol levels. So still suggestive that it's an important risk factor, both for your heart, but also for your brain. Okay, I'm going to whiz through part of the reason I asked to be able to advance my own slides is because I'm going to whiz through the next slides because I think it tells the story better than going through these slowly. These are maps of the US that show the proportion of obesity in this country. And just to orient you, and certainly we know the southeast part of the country, which is sometimes called the stroke belt because of higher rates of stroke, have higher rates of obesity than we see elsewhere in the country. And what I want you to look at, and it will not be subtle, I promise you, is how these colors change as I speed through the next basically 12 years worth of maps. And I have another 10 years of worth of this before that, but I didn't want to only talk about this during this presentation. So you can see that yellow means that a quarter to almost a third of the population in that country is obese. And by obese, that means a body mass index over 30. Green is sort of the healthiest proportion, less than 25%. Red is nearing 50% of the population in that state would be considered to be obese. And I'm just going to whiz through these, going through the years, and you cannot help but notice how the country is sort of being taken over by this obesity epidemic. We're seeing, I mean, now we're 2023 and almost the whole country is in the oranges and the reds, which is quite a difference even just over a decade. I find these really, really scary slides to think about what this means for the future health, both in terms of heart disease, stroke, brain health as well. So obesity in general, we know that especially in midlife, that obesity appears to be a risk factor for dementia. People that have greater obesity, as you can see here, greater body mass index, seem to have a higher risk of both what, at least in this paper, was called Alzheimer's and vascular dementia as two separate types. Here you can see there's more in sort of the vascular dementia. Again, I would say that VCID, that vascular contributions to cognitive impairment and dementia, is probably a slightly better term, but in general, we see certainly this risk. The one caveat to the story with obesity is that obesity tends to not look like a risk factor for dementia when you look in older age. Why is that? So one major possible explanation is that as people may start to have problems with their memory and their thinking, their dietary patterns change. Many people lose weight as they're starting to have poor health. There's a concept called the obesity paradox, which is in older age, obesity looks protective against things like dementia and other bad health outcomes. And that's because if you have disease, you're less likely to be obese, which makes it look like the healthier people have more obesity. So that's just, something to be aware of in terms of the relationship with obesity and body weight. But we do see this pattern when you look at obesity, especially from middle age, that it's a risk factor for dementia in later life. What about physical activity? So this session was started with some great physical activity, certainly important both for getting you ready to learn information, but also ready for, helps you in the long run in terms of risk of dementia. This is looking again in that middle age period in midlife and showing that people who were more physically active. So what this is showing is that this reduction in amount of risk. So this is sort of one here, means that your risk is the same as people who don't have physical activity. People who do have at least a moderate amount of physical activity in their spare time have a lower rate of dementia, really, irregardless of sort of what you consider statistically to understand why that might be the case. So more physical activity, especially in midlife, but also in older age, is associated with reduced risk of dementia. So I said that I would sort of come back to this idea, not just of what these risk factors mean for dementia risk, but what do we know about actually treating these risk factors? Can we actually reduce risk? And the short answer is we don't really have as compelling data that actually treating them does make a difference in preventing dementia. But there's a few reasons why. So first of all, most studies, what I showed you were mostly stories from observational studies, meaning that we evaluated people at multiple times, both studies that I led and that other people did, where we looked at what their behaviors were, how things changed. We evaluated them for dementia, not knowing what those behaviors were, and found these associations. Those take decades. First of all, I said midlife was really important, but we followed people for decades to understand those things. But when you do a clinical trial, which is where you give someone a medication, for example, or give them a dietary intervention or give them a physical activity regimen, and then you follow them over time, you have, first of all, you can't do that for decades. That's just not feasible to be able to sort of intervene and follow people carefully over that time period. But we don't see as clear benefit from those studies where we're actually giving people something. Some of it is because these studies are too short. Some of it is because some risk factors might not benefit as much if you start treating it when people are already older. We talked about that a little bit with this concept of midlife being especially important. But then one study did come out relatively recently, which I'm going to show you the results from in a moment, called the Sprint Mind trial. This was a trial where they wanted to understand, they said, well, these studies look like high blood pressure. If you have lower blood pressure, you have less dementia, less cognitive problems over time. So let's treat people to really aggressive, meaning pretty tightly controlled high blood pressure. So under 120 for the top number was their goal. They were not only looking at dementia, the broader study was looking at heart disease, strokes, et cetera. And they found an overwhelming benefit for those other cardiovascular changes, meaning better blood pressure control, less cardiovascular disease. But they didn't quite see that benefit for dementia. So just to show you these results, they wanted to understand if this intensive blood pressure control over 3 to 4 years. So that's part of the problem, is this isn't, you're not able to do the study for as long as it probably needs to be done. Intensive blood pressure control to below 120 for the top number, whether that reduces your risk of dementia. They did not see a reduction in risk of dementia, but they saw a reduction in the combination. This is showing you sort of that intensive treatment is the number of cases of dementia that they see over time. But the combination of mild cognitive impairment, that MCI entity, the in-between almost dementia, but not with the impairment in daily activities, and dementia, the combination of them was reduced by about 15%. So certainly supportive that controlling blood pressure, we know it's important for heart disease risk, we know it's important for stroke risk, it may be important for dementia risk, and I very much believe that it is, but that we just need a study that lasts decades to be able to show that actually treating it makes a difference in outcome. This came close to showing it even after only a few years. Other attempts to be able to see if treating people in certain ways made a difference in reducing dementia risk resulted from, so there was a study called the Finger trial. So this was done in Finland where people were randomized. So this was a clinical trial where half the people only got sort of some talk therapy, and they checked in with them to make sure they were doing okay. And the other group had more intensive cognitive training, control of those vascular risk factors that we talked about, like the high blood pressure, diabetes, et cetera, and had exercise as well as dietary modifications. So the people with that, what we call a multimodal intervention, diet, exercise, vascular risk factor, cognitive training, did better in terms of their memory and thinking over 2 years. Whether that translates to differences in dementia, we don't know yet. We also don't know how this translates to other parts of the world. So because this was in Finland, a lot of the diet, there was a lot of herring and other fish as part of that diet. It's not necessarily translatable to every culture all over the world. But actually, there's a whole set of studies called Worldwide Fingers, including the US Pointer trial. I don't quite understand what the interest is in the hands or the fingers in particular, but US Pointer is the US version of this, where this multimodal intervention is being tested, and we're going to find out hopefully within the coming months to year whether this shows a benefit in reducing that cognitive decline that might happen over time, but also dementia cases. What about aspirin? So I told you I'm a stroke doctor. These are risk factors for stroke. We know that aspirin has a benefit in people who have had a stroke. It reduces risk of a second stroke, and people with heart disease, it reduces risk of additional heart attacks. It's not necessarily beneficial in people who haven't yet had those. This is this idea of primary prevention, which, just for a brief tangent, is the idea that if you have not yet had heart disease or a stroke, the question is whether you should take aspirin just because you're trying to reduce those things from happening in the first place, as opposed to secondary prevention, which is you've already had one and you're trying to prevent another. So for primary prevention, there was no benefit in aspirin for reducing dementia or dementia-free survival in general, meaning keeping people alive for longer. And obviously we want to reduce dementia, but we also want to make sure that people have more quality years of life. And so there was no benefit from aspirin in that setting. So just very briefly to wrap up before, to make sure we have time for questions, I just want to touch on a couple of additional modifiable risk factors, because you might have seen them on that graphic that I showed you at the beginning that showed the life course approach, the Lancet Commission study. And inevitably, these are things that people ask about. So I wanted to just show them to anticipate that. Hearing loss is another really important modifiable risk factor for dementia. There's clear evidence that whether it's directly because you're not hearing things as well, so therefore you can't do as well on tests, or you're less likely to engage in social activities, so you're more likely to be isolated. And we know that that's an important facet of dementia risk, is being socially active appears to protect against dementia risk as well, at least in observational studies. So the ACHIEVE trial was a trial that close colleagues of mine conducted, where they randomized people with hearing loss but who didn't have cognitive problems to either get a hearing aid or not get a hearing aid. And although overall they didn't see a benefit from the hearing aids, in those people in that study who were generally at higher risk, so they were a little bit older, they had a little bit more of these vascular risk factors, those people did have a benefit from a hearing aid intervention. So even though their risk might have been in other areas, they were able to actually reduce their risk of cognitive problems over time. And even some of the brain imaging markers that we see over time in people who have hearing loss. So this is exciting in terms of a meaningful intervention that might actually be promising particularly for preventing dementia risk in older people with hearing loss. Sleep disturbances is another really important facet of modifiable risk for dementia. We know that certain sleep disturbances, sleep apnea, so sleep disordered breathing, or even not getting enough or getting too much sleep, have been associated with cognitive decline and dementia risk. And we're still trying to understand more, but it seems that treating that with things like CPAP, which is continuous positive airway pressure, which is the mask that some people get when they have sleep apnea, may be associated with better cognition, but the studies are not at all consistent. The jury's still out, so to speak, on that. And interestingly, medications to help sleep, if anything, it looks like they're associated with a greater risk of dementia. So that's clearly not the solution to generally reduce your risk of dementia if you have sleep disturbances. So just briefly, take-home messages, and then we'll open it up for questions if there's time. Risk factors for heart disease and stroke are also risk factors for cognitive decline and dementia, and almost half of cases of dementia may be attributable to these different vascular risk factors. I don't know why it's doing it in this strange order. Sorry about that. Pure vascular dementia as an entity is pretty rare. I'm just going to go through all these so that I don't get confused by the order, but having a vascular contribution to dementia is very common. In addition, hearing loss and sleep are exciting in terms of the research that's being done, but really additional areas where risk may be modified in terms of risk of dementia. And that in general, treatments aimed at overall health, lifestyle, diet, and exercise, reducing that vascular risk may be really important. And we're learning more about these in preserving your brain health and really reducing risk of dementia down the road. So with that, I will stop, and I'm happy to take questions if we have a chance. Thank you.
That was great. Absolutely fantastic.
Thank
There is a question in the chat that I can't answer. I've answered most of them, but as you went through, you gave us a lot of answers.
Okay.
It says, do you think Ozempic, that's the shot for weight loss, everybody, and other drugs like that, do you think taking Ozempic is going to help those of us who were obese or had diabetes? Is that going to protect our brains?
So it's a wonderful question, and it's a really exciting area of future research. And there are some studies going on that are directly testing that in certain populations. My suspicion is probably yes. Have no connections with the companies that make any of these drugs. The reality is there's pretty good evidence that that category of medications, these GLP-1 agonists is what they're called, appear to be associated with decreased risk, even of things like Parkinson's disease, maybe some benefit in Alzheimer's, even independent of its effect on diabetes, obesity, things like that. And certainly as people lose weight, their blood pressure is better controlled. So I think that's a really exciting area in terms of potential for reduction, where you might have a medication that affects multiple pathways to dementia, so to speak. We don't know until we do the studies, but I think that's an area that there's a lot of excitement about in the field. Obviously, none of these medications are without side effects, and you have to talk to your doctor about what makes the most sense for you, and what really is the most meaningful in terms of ways to reduce your risk. But I think that's a really exciting area for the future.
So just because there is a couple of questions on this is about medications.
Mhm.
One of them is we've been told for years that taking an aspirin protects you against stroke.
Yes.
Okay. Is that still something we should consider, particularly if we're hypertensive or we have high cholesterol?
So obviously,
that aspirin.
yes. The most important answer is talk to your doctor about your individual case, certainly. But you're right. We used to think that aspirin had a bigger role for this concept of primary prevention, which is that you haven't had a heart attack, you haven't had a stroke, you might be at somewhat elevated risk because of things like high blood pressure. And in more recent studies in the past 5 to 10 years, the evidence suggests that there's not a clear benefit in that setting of taking an aspirin a day. That being said, when those studies came out, there was sort of a panic. I was at Johns Hopkins at the time, so doing more clinical work than I am now. And a lot of patients, my stroke patients, called and said, oh, does this mean I come off the aspirin? I said, no, it's very different. That's for people who haven't had a stroke or heart attack. So if you've had a stroke or a heart attack, there's no question that aspirin or something related to it is highly beneficial in reducing your risk of problems down the road, including additional strokes or heart attacks. That being said, people that are really at a very high risk, who have diabetes, who have, a number of those risk factors that I mentioned, it may be that after discussions with your doctor, it makes sense for you to be on aspirin. But in general, it's less of a sort of blanket recommendation than it used to be for people that have not yet had things like a stroke or a heart attack, because the benefit didn't clearly outweigh risks of bleeding, for example. There's also other aspirin has benefits for people with sort of lots of colon cancer associated polyps, I believe. And so there's other benefits potentially from aspirin. So that's why a conversation with your doctor is really important. But the guidance has evolved a little bit in that it's less of a standard, blanket recommendation for everyone.
Thank you. There's another question on medications. We know that sleep, disturbed sleep or disrupted sleep is a risk factor for developing these disorders. What about taking sleep medicines? I mean, independent of something like CPAP.
Yeah, so it's interesting, and I sort of alluded to this briefly, that it looks like when we look at this and this is a paper analysis that I was a part of, when we looked at people being on sleep medications and risk of dementia, if anything, it looked like sleep medications, and I see there's also a question about melatonin. So not melatonin. We're talking about things like Ambien and those other hypnotic medications. People on those medications, things like Ambien, did have a higher risk of dementia. However, this is tricky because we know that people who take those medications are different than people who don't. It may be that they take them because their sleep is that much worse than people who aren't taking them. So it's unclear whether that risk that we see between these medications and dementia risk is actually due to the medications or due to the fact that taking them is a marker that your sleep is that much worse than someone else. So it's hard to study. This is one of those studies that in a perfect world, you would do a randomized clinical trial where you gave half the people with sleep problems Ambien or a related medication and other half not. But it's hard to do, especially once you've shown that there's this higher risk of dementia. It's not ethical, right, to give people a medicine that you think might increase their risk. So it's a little unclear still. Obviously, other ways to improve sleep hygiene beyond medications are probably better in general, but I realize that that doesn't work for everyone. But things like melatonin, we don't see any evidence that that's problematic in terms of, dementia risk, at least from the studies that I've seen so far.
Okay. Let me see where there was another one. Thank you for answering that Ambien question. I did see something else. Star Fraser wants to know about sundowners. I can tell her yes. Is that a risk? And truthfully, a lot of people don't really understand sundowners. So in view of the conversation we've had today about vascular disorder, does that syndrome, sundowners, occur more commonly in people with vascular dementia versus Alzheimer's?
Yeah, so I'm not familiar, maybe you are, I'm not familiar with people studying the rate of sort of the idea of sundowning, which I don't know if, I guess it looked like you have a lecture about delirium coming up, so maybe you'll talk about this more then. But the idea that people that have cognitive impairment and dementia often sort of late in the afternoon, evening, often start to get more confused and disoriented. And I think that it's not specific to cause of dementia. So people that in general have cognitive impairment have this. We see this when people are hospitalized, not infrequently, et cetera. But I'm not familiar with sort of studies showing that vascular versus Alzheimer's disease has greater or lower rates of that. But maybe you are. I don't know if
No.
okay.
Not at all.
Yeah.
In any event, I think that this has been a very, very informative session.